My name is Richard Marks. I'm an orthopedic surgeon and I have a subspecialty in foot and ankle surgery. My orthopedic surgery training was in Philadelphia at Jefferson University, and that was followed by a fellowship in foot and ankle surgery in Baltimore. I was fortunate after my fellowship to be able to go up to Dartmouth Medical College, where I started their foot and ankle program, and then transitioned over to the Medical College of Wisconsin in Milwaukee. I was there for about 2 decades. Most recently, I've been down at the University of South Alabama with their residency program. Well, with regards to ankle fractures, we see an entire spectrum of injuries. Lower energy injuries with clean fractures ranging all the way to high energy injuries which may have a great degree of comminution as well as soft tissue compromise. When a patient presents with an ankle fracture, we need to determine, can this be treated non-operatively or does this need surgical intervention? And that's part of the shared decision-making process, the relative risks and benefits of non-operative versus operative treatment. What has to be discussed with the patient is the risk of surgical infection, delayed healing, but also the contributions of rigid internal fixation that can help to accelerate the healing. Part of that conversation also revolves around expected length of healing, when patients can return to activities of daily living, and what restrictions, if any, they would have with their physical requirements down the road. Associated with the ankle fracture also can be some limitation range of motion, and if there is any articular disruption associated with the fracture, one needs to discuss with their patient the possibility of post-traumatic arthritis in the future. Initial conversation that I have with the patient is to describe the fracture, the degree of the involvement, our options, and the most likely outcomes. There's a misconception that an ankle fracture is just an ankle fracture. However, there is a full spectrum of injuries. So an isolated medial malleolar or lateral malleolar fracture that I know that we can reliably fix in a short period of time and get that patient back to every and all activities, that's an easy conversation to have. Once we get into more involved bi- and trimalleolar fractures, or even medial malleolar fractures that have articular involvement, then that conversation takes on a slightly different tone, in that we need to discuss fracture healing, the possibility of post-traumatic arthritis, as well as stiffness post-surgically. One of the more challenging issues, particularly with posterior medial or posterior lateral fracture fixation, is the soft tissue dissection and appropriate positioning of the patient. So that needs to be taken into account. In addition, we need to be cognizant of any soft tissue compromise. We're able to address isolated medial malleolar fractures, lateral malleolar fractures, or those with trimalleolar involvement. My personal approach is to reestablish articular congruity, and followed by that to get the most stable construct allowable. One of the biggest challenges, yet one of the most important factors in the choice of fixation, is understanding the personality of the fracture. And as opposed to trying to give each fracture a specific classification, there's a full spectrum of possibilities of both fracture pattern as well as fixation options. Over the past several decades, syndesmotic fixation has come a long way. The idea of a rigid concept where no motion is allowed through the syndesmosis is probably a bit less popular. the debate still remains 3 versus 4 cortex fixation, the size of the screw, when the screw is taken out, if when, but more recently the concept of flexible syndesmotic fixation has captured the orthopedic surgery industry to a much greater extent. Now with the introduction of locked fixation, how that might add additional stability and therefore improve healing rates and surgical outcomes. We also recognize the importance of the posterior malleolus and its contribution towards syndesmotic stability, and that falls into looking at these injuries really from a full 360, the medial contributing factors, the posterior, as well as the lateral contributing factors. When I am looking at a syndesmotic injury, there's a full spectrum, whether they are subtle, the injuries, the so-called high ankle sprain, which may have associated with that instability, to those patients with bimalleolar fractures with gross diastasis or separation, or those with a trimalleolar component where we now recognize that fixation of the posterior malleolus is quite important to the overall stability of the ankle. In a higher functioning patient, an athlete, or those that don't have gross comminution, then the flexible syndesmotic fixation option should be seriously considered. In those patients that present with more gross comminution and perhaps we're more concerned about the healing of the fracture and restoring the natural bony architecture, then having the options, particularly through a plate, is more appealing. Part of the conversation is, what are your functional requirements? A more active individual that would like to return to running at a higher level of sports participation, I would be more apt to remove that screw or opt for flexible syndesmotic fixation. In a more sedentary individual or one with poor bone quality, we may opt to leave the screw in, with that conversation postoperatively that one should be prepared to have that removed if the screw becomes an irritant or if it breaks. For me, personally and professionally, I've been lucky enough to be involved in medical student, resident, and fellow education, being able to participate in surgeon education. And the ability to convey new technology or new surgical ideas with fellow surgeons is invigorating. And that, combined with the newer technologies, allows us to provide across not only the states but the world the best quality of orthopedic surgical care possible. At the end of the day, it's better patient outcomes. And anything that we can do to advance technology or surgical techniques that allows us to provide superior patient care, that's the most gratifying thing of all.